Okay, so let's start. Bienvenidos. Welcome to the Serving Latinx Populations in Primary Care Behavioral Health. My name is Jaira Oquendo, and I'm the co-leader of this group. Natasha Perez Valle, she will be joining at some point. She's also the co-leader, task leader for this group, and we have been working for quite some time. And the main purpose is, of course, to deliver and organize this type of activities so we can continue having a space for our community to talk about the topics that we have. So I already share the website. You have the other two links that are actually working. As I mentioned, I posted the group purpose, so you can take a look, and it explains a little bit more what we're doing and why we're doing it. We will be having a webinar or community call next month. We don't have the information yet, but check your emails or Basecamp. You're welcome to contact me directly, and Natasha as well. For today, I will be monitoring the chat. Feel free to send questions to the panelists. The idea is to have a good discussion space on their experiences as trainees in integrated primary care. And this webinar will be recorded, and probably you got a notification about that. So the title of this panelist is Training in Integrated Primary Care as Bilingual Behavioral Health Students or Trainees. I am very happy to have Erika, Natalie, and Sammy here. I'm just gonna read a little bit of their bios so you know where they're at. I'm going to start with Erika. Erika Garcia Rocha is a bilingual postdoctoral fellow at Children's Hospital of Colorado. Erika earned her PsyD degree in clinical psychology from the Chicago School of Professional Psychology in Chicago. She completed her pre-doctoral internship at CU Anschutz School of Medicine in Aurora, Colorado, where she worked at Salud in an integrated behavioral health clinic, CU Boulder, ABL Clinic, a pediatric neuropsychology lab, and Reaching Hope, an outpatient trauma clinic. Erika has previously worked in schools, behavioral health, outpatient clinics, and community mental health center, conducting individual and family therapy with Latinx families. Her clinical interests include working to increase equity and quality of care of monolingual and bilingual Spanish-speaking families. And we were very, very blessed when she has spent some time at Salud. I'm going to introduce Natalie Garza. She's a doctoral candidate in counseling psychology program at Our Lady of the Lake University, where she's also completing a doctoral certificate in psychological services for Spanish-speaking populations. Natalie is currently completing her internship training at James A. Haley Veterans Hospital in Tampa, Florida. Sammy Tirado Lopez is a Puerto Rican psychology student in clinical practice who is in his 4th year of Albizu University's doctoral program in psychology, PsyD San Juan campus. He's currently in Colorado's Salud Family Health Psychology Training Program. Sammy's goal and aspirations are aligned with the ethical and commitment fulfillment of his role as a mental health professional. He wishes to promote and be an advocate for social justice and the promotion of healthy lifestyles that have an impact on physical, emotional, and psychological well-being. In his free time, Sammy enjoys surfing. I have heard about that. Hiking and spending quality time with his close ones. So as you can see, we have representation of interns, postdoctoral fellows, and a doctoral student in this panel, and that is precisely what we wanted to, because they already have a lot of interesting experiences. And so I'm just gonna let them say something before we start with the questions that we have for them.
I'm happy to be here and share my experience of primary care. I have 2 years of experience, so I'm happy to share my experiences.
Same, I'm glad to be here. Thank you all for making time out of your busy schedules to join us today. I'm looking forward to a great discussion with you all.
Same here, everyone. I also want to thank Dr. Oquendo and Natasha for getting this together. And my experience coming into integrated primary care was actually through an externship opportunity at Salud. And I've only had 1 year of experience, but it's been interesting.
Great. Yeah, thank you so much for accepting the invitation and being here. So the first question that I have for all of you is, how does training in traditional psychology differs from training in integrated primary care? What are your thoughts?
I can start. So I think one of the first things that I learned coming from an outpatient background to integrated care was this mentality of very rigid scheduling, very long-term therapy, and that was the most effective way of doing therapy. However, very quickly at Salud, I learned that one meeting with the patient was very helpful and how we could do so many things within a 15-30 minute span that I think traditionally we don't think of as treatment or care. So I think that was one of the first things I learned when transitioning to primary care.
I can definitely agree with Ms. Erica. The fast-paced environment, that switch from traditional to integrated primary care was a big shift, going from 50 to an hour to maybe 15, 20 minutes, and still being, or if not more effective, I think, with the time, given that we're intentional and really focused on the individual and what they're bringing, in addition to just the breadth of different things that you can encounter. You're not only focusing on the patient himself, but also the primary care team, which is one of the things that is a huge difference in shifting between those two types of training.
Yes, I completely agree also with Erica and Natalie. Actually, to report something a little bit different as well, the collaborative work that you have with other providers, understanding, their backgrounds, their expertise, and knowing how to use the team is definitely something that's completely new. I think the training in some way is different. Like Erica mentioned, our problem-solving styles are different when we're working in traditional psychology as to when we're working in integrated primary care. Our expectations for the clients are also different. And so all of those things were new to me, especially coming into working at Salud.
Can Sammy and maybe Natalie and Erica can also provide examples of, Erica mentioned that shorter visits with patients can also make a difference, right? Again, so I would love you to give an example. And Sammy, maybe if you can talk more about when you mentioned different expectations with patients. What are different expectations if we compare that with traditional psychotherapy?
Well, I think like Erica was mentioning, when we're focusing on traditional therapy, we're really looking for the long-term treatment, and we're already focusing on that we're going to be having a patient, seeing them weekly for a really long time. And so the goals that you have set in mind take a lot longer time than what you do in integrated primary care, where you aim for shorter goals. So your expectations for the client are in some way changing. You're focusing on their health, but at the same time, the goals are shifting. I think in my experience, that's one of the things that I noticed. And obviously, sometimes in integrated primary care, you have your first encounter and you only might have 15 to 30 minutes. And in traditional therapy, you feel like that's not enough because of all the things you need to cover in an intake appointment. So learning how to work at a faster pace, how to approach the more important specific topics with the client so you can actually assess like risk factors and safety concerns, and that amount of time was something that was really new as in integrated primary care.
And to add to that, I would say coming in with the outpatient mentality, I was ready to process and jump into processing when maybe the patient was just looking for a coping skill to reduce their stress for that week. And so we would come up with something that they could try for that week that was doable. And that's all they wanted. And they didn't want a follow-up appointment to process that. It was just, give me something that I can do today to help with what I'm dealing now.
So it seems that it was almost learning a different way of providing behavioral health services, and that's why different expectations as well.
Yes, and then just to quickly add, I think another change was going from how can I incorporate my family into the care as well? Because I think many times in outpatient, it's what can the individual do or the sole identified patient, but many times people wanted their family involved in what we call traditional self-care. And we think of self-care as an individual act, but for many of the Latino patients I saw, it incorporated like spending time with children, even though we think of spending time with children sometimes as the stressor, but for them, that was the curative piece for them.
Great, thank you for that. I think that especially in primary care clinics, you are seeing different members of the family, right? And potentially they're receiving care in the same place. So it's easier to also provide behavioral health services for and have an impact to the entire family. I'm curious about what will you say that are the skills that you had to learn, or yes, or skills that you didn't know that you had to kind of use them in an integrated primary care context, and maybe you were not using those before, or you did not have to learn those before.
I think two of the biggest skills I think I was using, but really had to fine tune and strengthen in integrated primary care was like my consulting skills and my time management skills, to be most effective to the team and to really increase access to care to all the patients in the clinic that are coming in. I think those were the two main skills I really had to like strengthen during my training in integrated primary care.
I think something that was new to me that I really worked on was the warm handoff. And so kind of this new person coming in, they really maybe have trusted the doctor, build that personalismo, that trust, and then having someone new come into the room, kind of navigating how to present myself, and that I was part of their team. So really presenting them as being on their side to help with whatever is happening, especially if the doctor felt like they may have benefited from talking to somebody or seeing us for therapy. So working on warm handoffs and how to present, especially if a patient was more hesitant about why a mental health professional was going to see them and kind of what were my intentions.
I think for me personally, it was definitely establishing rapport a lot faster and having to use your time accordingly to that. Also, being able to answer specifically the questions sometimes that your primary care providers were sending the consult for, right? Not trying to go too far off ahead, that you can actually have enough information in that amount of time to answer the question that is being posed.
Very interesting, and that also makes me think that probably you had the experience of working telehealth in integrated primary care. So I would love to share your experiences and compare and contrast if you had also the opportunity to work in integrated care in person.
Well, maybe I can start here because I did my whole externship through telehealth. And so it obviously created for me some fears, some insecurities on how I was going to be able to connect with a patient that I could not always see, and work with a team that I wasn't meeting in person. So that was definitely a challenge and very, very different to how I was traditionally working before. Also to just think about something, I was very worried of if I could actually engage the patient in therapy through just phone conversations. He would not see my face, he wouldn't see my nonverbal expressions to know if I was actually committed to his treatment. And so sometimes I know that's important for a lot of patients and clients, obviously. So those were my most concerns at the beginning of my practice.
I think one of the pros was that I was able to access more patients because we were calling them. And so we could catch them up many times as opposed for us waiting for them to come to the clinic. So I thought that was positive for accessibility. But I think one of the cons was we had to be more creative where they could talk and do their therapy, because sometimes the fear was, que la familia, so the family would overhear them, or they didn't want to know that other people wanted to know what was happening in their treatment. So we had to get creative with where they could sit for the therapy session. So cars, could they go to their backyard and sit? So we just had to be a little bit more creative too when we were doing telehealth services.
Yeah, one of the differences in the two, I've been fortunate to do both, was how to maintain that team, that getting those warm handoffs versus when you're in the clinic, you're kind of chasing and tracking down individuals versus when you're virtual, sometimes working from home. Versus virtual in the office, it's very different in the sense that you're constantly either on Teams or whatever platform you and your team share, trying to try to get some warm handoffs when you identify someone, when you've scrubbed. So scrubbing was a huge component for me to be able to stay on top of making sure I identify and prioritize who I wanted to try to catch while they're there. So that if they don't have access to video, like for example, a smartphone or a tablet or a computer, we would be able to set them up in the office if they were seeing their PCP in person. And so that was kind of, a different type of dance for me to adjust, but it's definitely opened the door to the possibility of continuing to offer these services, even as things get better, to continue kind of accommodating for individuals who aren't able to come into the clinic because of work and they can't find babysitters for the kids, or make that extra time to take off from work, because that's money, and how that much of a barrier that can be for access to care. So there's definitely a lot of pros and cons, and it's been a very interesting experience for sure.
Mm-hmm. I can imagine how challenging must has been to, and of course I know Sammy's case very closely because I have been his supervisor, to be learning integrated care at the same time that you're managing probably two ways of providing services in integrated care. So yes, many benefits, many challenges when working with telehealth, I can imagine. Also, or maybe this is a question for you, any challenges on learning or things that will have facilitated your learning process while providing services in telehealth that will be important to consider for future students who will be working telehealth?
That's a great, go ahead, Erica.
Okay, I was just going to say the transition from relying a lot on nonverbal cues to not seeing nonverbal cues. So whether what I was saying and what they were responding to, like, oh yeah, I could do that. Was it like a great, like they really were interested, or like, yeah, great, like learning to read some of those cues because I couldn't see their reaction, facial, their body cues. I was just relying on what they were telling me and the tone. So really shifting to those being my markers for building rapport.
Yeah, I also want to say having a really good set of headphones that you can actually hear those little breaths and in between where you can pinpoint if the patient's actually okay with what you're saying or not. And also a really good use of technology. There's videos now that are very, that could really help the process. There's a lot of worksheets that can be sent. So trying to maximize as well with the patient, obviously, if they feel comfortable enough to use the technology that way. So they can also kind of experience this new form of therapy through telehealth. So, yeah.
Yeah, my biggest thing, in addition to those that they've shared, is just how do I maintain this integrated level of care, and how do I continue to work with the team so that we can increase access to care to all, and that this computer or doesn't become a barrier, and it just becomes a way of strengthening and hopefully decreasing some of those barriers. So that would be my biggest thing, is just moving forward, making sure to check in with the team, that if we're not able to see PCPs or the nurses, that we're able to be there and when they need curbside consultations, or a quick hey, I've encountered this patient and they just kind of want to pick our brain and see what we can do. So just making sure that we're able to maintain that cohesiveness, even if we are island and state apart or miles apart, or even right next door with our doors closed, just given what's going on. around us. So I think that's the biggest thing for me.
How I would like to change the topic a little bit and talk about supervision. I wonder what are the differences between previous supervision experiences, maybe not in integrated primary care, and how is it supervision in IPC?
I love supervision in IPC. The fact that it's usually live, it's ongoing. They are constantly there. I've had the opportunity to do my practicum in a place where there's residents, and so I get to precept like they were doing, and it's just the whole process. So I thought that was a really cool experience, and just I don't think I've ever gotten so much supervision as I have in integrated primary care. The supervisor's constantly there. And if it's not through Teams, or if it's not through video chat or in person, or however it may be. So I thought that's a really cool experience compared to just traditional, where we may meet once a week, kind of just staff cases and talk about any barriers or things that are coming up, and then kind of be done. Just check off that box. That's what I felt like, at least from my experience.
Yeah, I also completely agree, Natalie, and it's not just because my supervisor is here, but I actually felt that it was just so much more attentive. I had more opportunities to reach my supervisor at any time during, my practice in vivo, in-person supervision, where she would supervise me right there with the patient. That obviously provided like so much information that wouldn't be accessible if you're meeting just once a week and they're just discussing a couple of cases. Also, just the supervision in the way that it's a little bit different from traditional supervision in my experience, also that you focus more as well on trying to understand the biopsychosocial model. So you're working with the psychopharmacological treatment that the patient is at, you're working with the care managers that he's at. So you're reaching and you're trying to understand all of these other providers' goals in supervision, so you can as well help to, to promote for the patient to reach those goals, and what you can do to help the team as well. For me, it was definitely that. I guess the only con I can say is that sometimes you can have so many cases that you just are like feeling that it is never enough time to discuss all the cases and everything that you want. So they can choose your questions and be very prepared for supervision.
Yeah, I would agree with what Natalie and Sammy have said, and just add that I feel like integrated care is very much team-based. So if there's a question, you can consult with the other providers and get an answer then, instead of holding all this information and presenting your cases week by week, which then puts back the time of making progress, as they call it in outpatient, or making, I can't find the word, but just like moving forward. And I think that you can just, especially if you're like in there with the providers and not co-located, so you don't have to fill out ROIs and then wait for them to call you and then you play phone tag. You can just go and talk, I have a question about this health problem and how it may be impacting the presentation. You can solve these issues and then bring it in supervision and really have an answer much quicker than working in co-located or where the services are outside of the clinic.
Great. Great advice for supervision. I would love to hear all of you are bilingual trainees, you're working with the Latinx communities. I would like to start with your experience as a bilingual behavioral health trainee. Maybe the challenges that you have faced, or anything that you think will be important for us to talk, considering the capacity that you have to provide services in Spanish.
I think the biggest challenge for me as a bilingual trainee throughout my education was finding supervisors that were bilingual. And I think that was the most challenging thing, because I was providing services, in Spanish and being supervised by English speakers. And so that was a challenge. And so when I first started with integrated primary care, I had the luxury of having a bilingual supervisor, and just being able to have supervision in Spanish. It just changed that dynamic, that experience for me, in addition to being able to practice and talk about different brief interventions that I can utilize, and that being in Spanish versus just me translating, which I thought was doing a disservice to the patients I was working with. So I think that was some of the things that came up for me.
Yeah, I would definitely say that the language barrier can play a piece, especially because not all words from one language translate to another. So then you have to explain these nuanced concepts that we feel understand, but maybe someone who speaks a different language does not. And so we were trained in English. So yes, Spanish is my first language, but I know all these terms in English. And so there is a little bit of, I feel like, lack of confidence in then pronouncing some words or feeling comfortable explaining terms because we learn these things in English, or at least I did. And so some ways I found to navigate that are finding materials in Spanish. Sometimes I've had to create my own materials. And then seeking guidance to see if there are other providers who maybe have come across some of these same issues. So whether it's starting like a supervision group with other people who identify similar as you, so you can discuss, like, does anybody else go through this? And it doesn't feel like such a lonely, isolating experience.
Yes, I completely agree with that. For me, it was a little bit on the contrary. My education was in Spanish, so when I went to try to say the terms in English, I was having a lot of difficulties. And I was also not feeling very confident when I would be in a conversation, especially if it was with a provider and I had to explain certain type of concepts. My mind would just fluctuate from Spanish to English, and I would fear that in my conversation, I would start talking Spanish or English, whichever it was. So that was definitely something that I was always trying to be very present, at least in the beginning. Once I started to feel more confident, it was okay for me to sometimes ask for, let me take a break and process this word so I can say it to you in English. So yeah, that was definitely one of the themes. I think also that lack of confidence at the beginning of not feeling so comfortable providing services in English, and for me in particular, it sometimes hold me back from, having consultations with providers through telehealth where I can actually give them a contact, because I was always try to think about the questions and write them and pose them in a way that was, as appropriate as they could, so they can actually understand what I was trying to say, instead of just very quickly, hey, do you have a moment to chat and let's try to solve this together? Can you give me, can you answer this question for me because I'm having a doubt? So that made me use too much time trying to figure out those questions on my own, instead of just using the team very, very quickly.
You mentioned very important things in the previous question, the challenge of not having bilingual supervisors or supervisors who are working with the Latinx patients, that it's something very significant, especially not only because of language, because the patient can be Latinx and being and prefer language English. It's also everything that is tied to the language itself and the cultural identity of that person, right? So that's something that needs to continue. We need to continue to pay attention to provide spaces for bilingual trainees to have bilingual supervisors, for sure. I really like the diversity between you, right? When we think about bilingual trainees, we are not necessarily, we're thinking that they can speak Spanish, but we are not necessarily thinking about the differences between, oh, my first language is Spanish, my preferred language may be English, or I'm in between, or my first language is Spanish, my preferred language is Spanish, my education was in this language, or my education was in English, right? So I think it's very interesting that those pieces, because how is training in integrated care, or in general, right, in psychology, considering the fact that language preference and first language from the behavioral health trainee. So that's something very interesting that you're bringing up, which also takes me to this other question for you, right? So as bilingual behavioral health trainees, what can you tell me about providing services for Spanish speakers in an integrated primary care context?
I think one of the things that I was afraid of in having supervised other trainees who are also maybe English speaking but are working towards providing services in Spanish is not all words are the same across cultures. And so, being afraid to say something that you don't understand, or the client says a word and you're like, I'm not sure what that means, and then being embarrassed about it. So I think that and I've told my supervisees as well, use it as a learning experience, empower the patient to then teach you, oh, I'm unfamiliar with that word. Can you tell me a little bit about what that means in your culture, or what that word means for you? So using it as a moment of teaching and empowerment. So then that way it becomes a conversation of learning and not about embarrassment, because you can't know all the words across all the cultures, across all the different Spanish speaking languages.
I love that you pointed that out, Erica. I had one of the supervisors when I first started my doctorate program, and she was my Spanish supervisor. And one of the things that she would have us do when we'd meet a client was introduce where our Spanish comes from, and just kind of opening that door that I may, some English words may slip out, or I may say a Spanish word that, either, just different that may not be known. And so please feel free to ask me, or, kind of just opening that door of that can happen. And so I thought that was a really cool thing that she taught, me to do, about just kind of talking about where does my Spanish come from, especially because all the other trainees that I was with in that Spanish group were at different levels. Some were, first, Spanish was their first language. Others were just learning through their doctorate. And so it was a really great experience just to see the differences in the ability of, that kind of, sometimes it could hold us back. We could be kind of, not sure, did I say that correctly? And some words may not come out correctly. Sammy, to say, I don't know how many times I've come to a huddle and I'm speaking Spanish because I just came from a Spanish consult, or English to Spanish, and they're all looking at me like, and I'm like, oh, and I catch myself, I'm in the wrong language. And so let me change channels. And so just being able to have these conversations and, kind of opening that door, I think that's a great thing that I've learned throughout my training.
I really like that idea, Melody. I actually had a couple of patients of mine say, your accent, I know that's Puerto Rican, right? And I was like, how could they know, when I was trying to mask it as much as I can, but obviously we can't. So definitely taking into consideration, just because you know Spanish doesn't mean that you aren't always going to be able to understand every word and the meaning of the word behind it for the patient. Not being afraid to ask, what does that mean for you? Can you explain to me a little bit more? For me, it really helped also to try to understand a little bit the historical context where the patient came from. There's obviously his generation, if he's first generation, second generation in the United States, trying to learn, Mexico, example, if a patient came from Mexico, Mexico is really big. What part of Mexico did he come from? What religion he followed, what cultural values he shared. And that was really important for me, to not try to impose my own cultural values, just because I also believe I'm a Latino and we can share similarities in our beliefs and in our values and what we think is good or wrong. And those are conversations that were really important in supervision.
So the question was the most challenging aspect about being behavioral health trainees in integrated primary care. It's fascinating to hear about the differences in terms of where your Spanish is coming from. And I have here a question from Neftali. Thank you for joining. And maybe you can expand a little bit more on this. I know that you touched on a little bit. How have you worked on building skills in all of the Latinx subcultures? Mexican, Puerto Rican, Dominican Republic, Peru. I'm curious, as students, how you educate yourself on these nuances. So what can you say about that?
I think just practice and taking those consults. I think initially I was afraid because we also speak Spanish at different levels or different speeds. And so for me, it was just like, the more I listened to people who spoke Spanish a little faster than myself, so from other cultures, that is the way where I could find myself like understanding them, because at first I was like, oh my God, could you please repeat that? Because I was just trying to focus on the words, but they spoke it so fast as well that I was like, I'm trying to make sure that I'm showing that I'm listening to the patient, that I'm catching what they're saying. But I guess the only way to do that is practice, 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 and have those opportunities. So then you can tune yourself to different rates and words and speeds of Spanish.
I would say, if I had to just kind of sum it up, curiosity. That is the biggest thing that has helped me in just being curious about that individual. And like Sammy mentioned, just because they may identify with the Mexican culture or they're from Mexico, if you've ever, encountered different cultures within Mexico, just from north to south, depending on where they're at, it changes a lot. I know that from my family who's from Spain, that's the same thing. Northern, southern, central, it's all very different. The Spanish is different, how the words that they use, how everyone expresses themselves, the cultures, the traditions. And so I think curiosity has been the biggest thing for me, is really being curious and really wanting to identify, just because they may self-identify as Puerto Rican or Dominican Republic or Mexican, really, what does that mean for that individual that's in front of me? How does their context look based on their concern or the referral I've received for the consult? So.
Yeah, I really appreciate what Erica and Natalie just said. I think that sums it up pretty much well. You have to have the curiosity, but you also have to work in a pace with your patient, and you have to take time to understand them, because everybody's very, a unique person and in their own way. So even if they come from Mexico, they're going to have different qualities, different ways of managing their problems, and different goals as well. So having that curiosity, being empathic, establishing that rapport, and just trying to focus as much as you can in your free time to know where this person came from, to know what his historical context is, to know what his beliefs and his culture were at that time where he was living, and just try to understand that as much as you can. I think as well as just experience, practice, and yeah, that's the only way I think it can be done.
Following that question, Neftali, is asking who taught you that. I'm curious how you all got there.
I think sometimes when there aren't supervisors who are there to guide you, you have to figure out a lot of these things out yourself. So I just put myself in the position out there to be, like Natalie said, curious and gain that practice. As I feel like if I reflect back, maybe 2 out of all the many years I've been in grad school, 2 of my supervisors maybe spoke Spanish and the rest did not. And so I've had to find different ways to kind of scaffold materials and explaining terms. So I think an important note to note is that sometimes your trainees are doing these things themselves and it's very stressful. So if you have an opportunity to talk about, how exactly, like who taught you that, like where are these things coming from, can be really important, because then it shows that you are listening to them, your trainees, and also if they're feeling stressed or lost, then maybe together you guys can come up with a resource or a way, so then that way it doesn't always fall on the trainee to come up with the resources or the responses or the answers to things that a system that's taking on Spanish speaking patients doesn't necessarily help the trainees to then adequately provide services, because there are all these other factors getting in the way.
I definitely can agree with that. And also to add that it goes beyond just our education. I think a lot is through our lived experiences that we gather through, of course, our education and the practicum sites and the internship sites and the postdoc sites and the jobs, and also just being involved in our community, traveling, really immersing ourselves in other types of experiences that can provide us some of these skills or knowledge that can really help us become a well-rounded psychologist in primary care.
I think for me, I was fortunate enough that in my externship program, these were topics that we were talking about when I started. You know, they were actually giving us trainings, they were giving us literatures, there were phenomenological studies where you're actually, you know, learning from the experience of the patient and what they're expressing to their providers and getting to understand, you know, how they see us when they're with us and when they're working with a bilingual provider, when they're working with somebody who's trying to understand their history, who they actually are, and their actual needs. So for me, I was just fortunate enough to have those conversations in supervisions and group supervisions, and also in these specific trainings when we would review a certain certain literature or investigation that was done.
We have another question here, very interesting question. What is the most important thing you have learned from Latinx supervisors, Spanish-speaking supervisors?
I think one important factor is it's like know your role. So for example, if you're there to provide behavior therapy services and you're being asked to do translating documents and all these other jobs that people study and get paid for, and I think as a trainee, it's hard to sometimes say no to things because you're being evaluated or you feel like other people have power over you. I think I've learned to advocate and say, like for example, now in order to provide Spanish services at Children's, you have to take a test, like a qualified bilingual staff member. And so some doctors still say, can you quickly like translate this for the patient? And I say, actually, because of policy, I can't do that. So before I was afraid to speak up for myself, and now I just use like the policies to say why that's wrong or why I can't do that. Because first, I'm not getting paid for that, and that's not my job, but also it's a policy. And so then other people who will get paid for these services, that is what they're there for, to support us with that piece.
This is a great question. And I'm trying to think what's the most important thing I've learned, because I've learned a lot. I've been very fortunate to have Spanish speaking supervisors. Not many. I think I've had a total of maybe 3 throughout my entire training. And so I would say probably the most impactful thing I've had was being able to gain resources in Spanish and actual protocols and things that how to properly say things, and versus just me trying to come up with like the translation. And I think that was the most helpful thing, you know, like when discussing the cognitive behavioral model, you know, really being able to say that and go to actual, you know, documents and research and, you know, things that are established and be able to draw from those and not have to come up with them myself. So I think that was the most helpful thing, of just having those resources that are in Spanish.
Yeah, it is hard to try to sum up, you know, all the things that we learn and choose one. But if there was something that I could pick, I guess I would say that, you know, knowing the importance of a bilingual provider and the importance in the team of having somebody who can reach the patients in their primary language. So that definitely was something that to me was very surprising, just the need that there is in the United States and different parts of the United States for bilingual providers, and how much that can actually help the teams.
Something that I don't think that it's a point of conversation very often. It's the big challenges of behavioral health trainees when they have to move and relocate. Yes, that's a challenge itself, but the other challenge is how I'm moving from the East Coast to West Coast and what I'm going to be provided in that process to learn the culture of that new place that I'm working at. Because the Latinx communities there can be very different from the East Coast, for example. And in Sammy's case, right, you're also, not only you, but I can imagine how all of you have been navigating 2 challenges in terms of cultural awareness, the Latinx community, but also the English speakers of this particular place that you are working at. And sometimes I feel that we talk a lot about bilingualism and the importance of develop that cultural competence. But what is going on when a trainee moves to another place and is providing integrated care services, for example, in this new rural location, and you were used to work in inner cities clinics in integrated care, right? So just another point of conversation at some point. I want to take maybe the last minutes to, I would love to hear, what do you think that are the most, the biggest challenges about working with the Latinx population in the primary care? And the opposite, what do you like the most about working with the Latinx population in the integrated primary care?
Well, I feel like for me, the most challenging was definitely the language, right? We could speak Spanish, but there's different concepts to that. Also learning how Latinx populations from different countries just have a different way of thinking of their problems, and especially their mental health. So trying to understand that was really important for me. And it took me time to really work, like I said before, at the pace of the patient, and not try to push them or rush them to where I thought they should go. Interventions and choosing which ones were helpful and which ones were useful for the patient. That was really important. And maybe the things that I really enjoyed for working with them is just hearing the stories of them saying, you know, for the first time I feel heard, for the first time I feel understood, just because they were able to work with a provider who took the time to talk their primary language and to understand, you know, their needs in a way that they could actually express, they could fully express and comfortably what they thought was important for them to know at that time, to be able to break barriers for them, where you could facilitate coordinating certain resources for them, or coordinating appointments with doctors, or trying to help them understand better the medication treatment that they had planned for them, or the labs that just came out, and giving them that ability of not being a translator, but just helping them bring the questions to the provider, helping them access better the resources and which ones were available to them in the community that could work with their primary language. So that was just really gratifying for me, and just obviously hearing them say that it was the first time that they could work in therapy in Spanish, and how that changed so much how they felt in the relationship, and how much it helped them just be able to feel more motivated to come to therapy.
I think for me, there were two things. The first one is, even when you say translating materials, a lot of these materials were based for individualistic, very different perceptions of the world, just like Sammy was mentioning. So you're not only translating materials linguistically, but also incorporating those cultural pieces, which are very nuanced and important to the Latinx population. So I think that was one of those pieces where, yes, there are treatment materials that show effectiveness. However, they're standardized for very different populations with very different values. And then the second thing are the gray areas between laws and how much families want you to share with them, especially if your identified patient is like a 12-year-old. And so they want to know what's happening. They want to be involved in the treatment. And then that's where the gray area lies of how much can you share and how much is the patient willing to share, so their family knows what's going on without the family feeling like you're not in, how do you say, like involucrando, like involving them in the treatment of the child or the patient. So navigating those, the law versus family involvement.
Ooh, so I think some of the benefit, of course, Spanish is my first language, so I love speaking Spanish. I'm super biased, but I love the richness. I also know that one of the challenge can be, if I want to be intentional and really be mindful of my time, sometimes Spanish takes a lot longer for some reason, especially as a beginning trainee. It took me a lot longer. It's not, you can say something in 1 or 2 words like you can in English. It takes almost sometimes like a whole paragraph to say the same thing you're saying in English. That may take you only 1 or 2 words. And so that was a challenge, while still making sure that I'm available for others. But I think something that Sammy highlighted that I really appreciated was the fact that also understanding where they're coming from, how their culture views what we do, our services, and being open-minded that we may not be the only thing that can, be as one of the resources to address their concerns, and being open-minded to involving other things in the community that may be more in line with their cultural beliefs and their values in addressing their concern. So just being aware of the communities that are part of your clinic, and what other types of services they they rely on versus our attention, psychotherapy, or psychologists. Sometimes I'll just kind of being able to understand that, I think, is a huge blessing and an area of growth for us for when working with Latinx populations.
There's a question here, and I think that we have a couple of minutes to address that. And it's, can you describe the kind of leadership mentoring, preparing you for leadership you have received, or do you feel that you could have received more coaching to prepare you for leadership?
So I would say that something I learned is to make a greater impact is sometimes you have to be the person to be that supervisor to facilitate these opportunities for others, or create an opportunity where other people feel like their experience is heard and seen. So something that I'm doing at Children's is creating a Spanish supervision group for all levels of trainee. And so it's a work in progress, but at least we're trying to create a space where people can come and ask questions about, how do you say this? Or I had this experience with a supervisor, because if your supervisor can't answer your questions as a trainee, that can be very stressful, because then who do they go to? Who else can they ask or talk about some of these topics that we have covered that come up when providing services to Latinx populations? So that's something that we're trying to create to help others be heard and seen that have similar experiences as Samuel and Natalie.
When I think about what kind of leadership mentoring I've received, I feel like it's been more of, they push me into it, and then they'll be like, I'll be here, but they just kind of want to see me try to swim first, and then they'll kind of throw a few things, to help me float. That's the kind of leadership mentoring I feel I've received, yet really being able to network, and I think just establish these relationships, your communities, and maintain these ties, because I feel that as I continue to move through with my career, a lot of individuals, especially in internship, have offered to have this unofficial mentoring if I ever was interested in it, if I ever need it. And so I think that's been helpful. I found that to be more helpful, these unofficial mentors, than my official mentor I had during internship. And so I thought that was, just being able to have those sidebar conversations have been really helpful, and just being able to see the different types of leadership roles that they play and their style has really been more impactful for me.
I think that one's a hard one for me. I haven't had much experience since yet with leadership mentoring, but last year in August, when I came into the externship program, was the first time that I heard that a psychologist or a therapist or behavioral health provider could be an advocate, and how we could use that to communicate the needs in the community about what patients were needing. So for me, that was also like a little push, kind of like, here, see what's going on, and then we'll kind of give you some tips so you can kind of navigate now. And yeah, I think that was really important, because I always had an idea that, a psychologist who's going to be a leader is somebody who's working in some organization, is creating some community programs. But I didn't understand, even from a private practice, or even from your own, just working in a clinical setting in an integrated primary care setting, you could still be an advocate for the patients, and you could still be a leader in a way for your team. And yeah, so I think that was just some of the reflections that I can make on that point.
Thank you. Well, we have 4 minutes left. Any final comments, anything that you would like to share that we did not ask you? final thoughts, final advice as behavioral health trainees in integrated primary care?
Oh, one final thing that came to mind when talking about, what are some of the challenges with Latinx populations that I've encountered is balancing those boundaries as a professional. A lot of times with Latinx populations, I've had them bring me food or want to bring gifts, things that they do just based on our encounter. And sometimes this was just drawing some of those boundaries and making sure when to accept something or not, or physical, like wanting to hug or, greet me in a certain way. That definitely was something different from like traditional psychology to integrated to when you're working with the whole family and you're just having to navigate all that. So that's just something randomly came to mind. Last minute thought.
Yeah, very similar. Sometimes I've had patients over identify with me as like a daughter or like a hija, which they mean as like a term of endearment. However, making sure like those boundaries are clear that I am a provider and we're working on things, but still doing it in a way where it doesn't insult the patient. Because you do care about the patients, however, just being aware of those boundaries.
I think I can say something final. For me is just take your time to get to understand your patient and make sure that they understand what you're saying to them as well, even if you speak the primary language. And I really like an advice that Natalie said, just be curious in your profession. And that also just brings up so much information that's going to be useful for you.
Well, I appreciate Natalie, Erika, and Sammy for sharing their experiences. I think that we have to give opportunities for behavioral health trainees to share their experiences, because I do think that we as supervisors, our leaders already, as psychologists who graduated a couple of years ago, we can learn a lot from all of you. So I appreciate everything that you share. So, and thank you for all of the participants. I hope to see you at our next activity.
Mil gracias. Thank you, everyone.
Thank you.
Thanks everyone for the opportunity. See you guys.
If you can stay on for some minutes, we'll